Hello, and thank you for taking the time to watch this video. My name is Crystal Duarte, and I support the Perinatal Health Initiative, which is an initiative of the Substance Abuse Prevention and Treatment Agency, or SAPTA, at Nevada's Division of Public and Behavioral Health, or DPBH. This training will be conducted in a roundtable discussion format. I'd like to introduce the panelists before we get started. Dr. Deepa Nagar is a neonatologist and is affiliated with Dignity Health. Sharon Savage is an assistant manager at Clark County Department of Family Services and oversees the Comprehensive Addiction and Recovery Act, or CARA program. Dr. Farzad Kamyar is a psychiatrist and the director of collaborative care for the Maternal Opioid Treatment, Health Education and Recovery, or MOTHER program at the High Risk Pregnancy Center, and is also with the Empowered program at Roseman University of Health Sciences. Rachel Mack is the associate director of the Empowered program at the Roseman University of Health Sciences. So let's get started with our first case scenario. A 32-year-old woman unintentionally becomes pregnant. At the first prenatal visit, she discloses cannabis use to alleviate nausea and vomiting. The OB provider does not discuss the need to develop a plan of care with her during this visit. She makes all of her following prenatal visits. At delivery, in conversation with the nurse, she mentions she used cannabis to alleviate nausea and more recently used it recreationally. So for our panelists, and I think we're going to begin with Dr. Nagar talking a little bit about our the three populations for birthing people for whom a CARA Plan of Care is needed. But the questions we have for this case scenario are, how would you approach determining the need for a CARA Plan of Care in pregnancy and during the birth and hospitalization?
Hi, this is Dr. Nagar. Let's review the three populations of birthing people for whom a CARA Plan of Care is needed. Number one, using legal or illegal drugs, on an opioid medication for chronic pain, or on medications such as benzodiazepines that can result in a withdrawal syndrome and does not have a substance use disorder. Number two, receiving medication-assisted treatment for an opioid use disorder, buprenorphine or methadone, or is actively engaged in treatment for substance use disorder. And number three, misusing prescription drugs, or is using legal or illegal drugs, meets criteria for substance use disorder, and not actively engaged in a treatment program. So in this case, Dr. Kamyar can shed some more light.
Yeah, so as Dr. Nagar mentioned, some of the criteria for who is a substance-affected infant, and as we can see in this case, I believe it is the patient in this case is actually admitting to, right, hey, I've used. So that automatically sort of meets the criteria, right, that this patient is stating that they've used, and they're maybe having a substance use disorder or not. But sort of continuing on this line is, well, we got lucky in this case, someone admitted to using, right? But I think it's important to stress what are sort of the evidence-based best practices when it comes to what we call screening for substance use. And that's an acronym you may or may not have heard, known as SBIRT. So screening, brief intervention, and referral to treatments. And why it's important to engage in that is that that's sort of the best tool that we have to date in identifying those that are using substances. It's sort of contrary to what we may be engaging in or common practices, which are urine drug testing or biologic testing, as we may call it. But in this case, the best practice of screening is using something that we call a validated, accepted questionnaire and performing the screening universally. We won't get into a lot of the nitty-gritty details on what this is, but a couple key terms here are validated, accepted questionnaire, which means this is a tool that is backed by some evidence. And we've designed some provider reference guides that are available through this initiative. But one of the ones that we sort of recommend is something called the 5 Ps, P as in Paul, and it's questions that are asked of a client or presented to a client. But another key here is universal, and that means every single person that you encounter, whether that's someone who's engaging in prenatal care or someone who's coming to the hospital to deliver, you want to ask every single person these questions and not engage in what we call targeted screening, which is you look a certain way, you're a certain race, et cetera, which is highly unethical.
In pregnancy, it's really important for everyone to understand and especially educate the women that there is no known safe amount of cannabis during pregnancy, and opening the door to offer any additional supports that may be needed. During this hospitalization, the care team should be looking at the patient and definitely the family and support system as a whole to determine the need for plan of care, and looking specifically at the effect of any use on the infant. Cannabis use in and of itself should not trigger a plan of care unless there are extenuating circumstances or there is significant impairment. Also, from a medical perspective, exposure is a yes or no question. And in this case, there has been an exposure. But determining if the infant has been affected is key for initiating a plan of care. As a neonatologist, it's really important to understand that this can really affect the baby in multitudes of ways that may not even be addressed right at the beginning when the baby is born, and may be noted over time. So for us, when we are reviewing babies, we look at all the different issues. However, sometimes we have to be careful to realize what is being affected by medical issues and what's being affected by cannabis. Even if a plan of care is not completed, providers can still offer resources and educations to the families, so they understand that there are many effects to the baby even after birth, and milk that is being provided, the breast milk that's being provided, can have significant amount of cannabis and can go to the baby and affect the baby.
Thank you. I have a question on this case for Sharon. So how is child welfare approaching cannabis use, and what services are available in the community?
The intake team at Child Welfare is the responsible party for doing our initial assessments when families are brought to our attention. Included in that is cannabis. So seeing in the scenario that's provided, that is something that we do frequently see. So intake is responsible for gathering additional information to make a determination on whether or not we will assist this family, because there are formal services, informal services. We can also look at what supports that family has and look at prevention as well as supportive services. So as it relates to cannabis alone, without any additional information from the person making the report that indicates there's concerns with maltreatment or the safety of the children, would not necessarily rise to the level of an assessment for the next level of assessment with the child welfare agency. And so each family is assessed on an individual basis. So it's not a cookie cutter situation that all cases that come in have to fall into a specific category. We want to make sure that we're doing our very best to understand what does the impact of the substance have on the caregiver, as well as prenatally that exposure to the infant. How does that come in and play a role in how the development of that child is going to be? So when we receive the information, we do additional information collection, and then we also try to find out, how does the family function on a normal basis, on a day-to-day basis? How does that adult function? What are the concerns for the child and how they're functioning? And what information do we have from the hospital that would indicate that there are some concerns about abuse or neglect, or some type of maltreatment, or the ability to be able to provide for the care of that child? And so we do have supportive and prevention services. We work with a variety of different community agencies. Specifically in Clark County, we work with the Southern Nevada Health District. They have programs that they're able to offer for the family. We also work with the Foundation for Positively Kids, and we work with other agencies that might be able to provide some in-home family services on a preventative nature. So each family has the ability to come into our protective custody situation where we're looking at whether or not we need to be involved or not through that child welfare agency. And so as a result of that, we want to make sure that we're doing the very best that we can to assess, determine the needs, and then take next steps as appropriate. And so it doesn't all end up being one way for one family versus another. It's based on those specific needs and the information that we have available to us to make informed decisions. So it doesn't have to be a negative situation. People have a tendency to think of child welfare in a negative light, but we really are in a helping role and want to do the very best that we can to assist and to help families, which includes those that may be using cannabis.
Thank you, Sharon. And Rachel, is there anything you wanted to add regarding this case?
No, that's good. Thank you.
Yeah, in that case, we will move to case scenario number 2. And we have quite a few things to discuss on this one. So a woman with a long history of opioid use disorder is on medication-assisted treatment with buprenorphine and has been doing well in recovery for 14 months. When labor begins, she reports to the hospital closest to her in rural Nevada, but is transferred to Clark County where she delivers. So does this hospital need to make a report to the Child Welfare Agency in this case scenario? And what are the important factors to consider in determining whether a plan of care is indicated in either scenario, in any scenario? So Rachel, we'll start with you if you want to kick us off on this case scenario.
Great. Just as Dr. Nagar mentioned before, those 3 main populations of birthing people whom a CARA Plan of Care is needed. Just to highlight those again, individuals using legal or illegal drugs on an opioid medication for chronic pain or medications such as benzodiazepines that can result in withdrawal symptoms and does not have a substance use disorder. The second one is receiving medication-assisted treatment for opioid use disorder. That could be buprenorphine or methadone, or is actively engaged in treatment for a substance use disorder. And that third population that we look at is misuse of prescription drugs or is using legal or illegal drugs and meet criteria for a substance use disorder, but not actively in a treatment program. So this case scenario actually highlights that second population receiving treatment for an opioid use disorder and actively engaged in treatment. I think it's important to highlight for this case that a CARA Plan of Care is needed for that reason. Also because this client is in recovery, it doesn't mean that they can't benefit from any supportive services or any other resources in the community. I know a lot of what we see within POWER program, even though clients are in recovery or receiving treatment, they can usually benefit from additional supportive services, whether that's peer support, any other services to help them with stability. That could be housing assistance, utility assistance, transportation assistance, identification documents, especially as they're preparing to bring their baby home. There's still a need to support them and prepare for that new stage of their life and preparing for that discharge. So from my experience, even though clients are in treatment, there is still a need for supportive resources that they can benefit from, and that's for them and the family.
And I would also emphasize that in these scenarios, polysubstance abuse is definitely a concern, meaning mother is on more than one substance. And with this process, if it is done early during the pregnancy, the support services and or getting her the medical treatment that she needs, we can bring her to a place where she is in a much better healthy scenario for herself. She's on one substance, prescribed opioids, for example, instead of multiple illicit drugs or other drugs. And this would improve the baby's outcome when the baby is born. When the baby is exposed to multiple substances, they can have many more needs in the hospital and a much longer hospital course. So to reduce those issues and also long-term developmental concerns by opioid exposure and substance exposure during pregnancy, if we can give mom those supports during pregnancy, help her get the care that she needs, when mom is healthier, baby is healthier. And then the baby does much, much better in the hospital. Now, if we're talking about hospital and what support that mom could potentially get, we have a multitude of processes that are there. When mom is delivering, we always like to educate prior to delivery so that she can understand what the process would potentially be for the baby, because not every baby withdraws when there is opioid exposure, especially if the baby and mom have gotten good care prior to delivery. But if there's polysubstance use and or other challenges, there can be quite a high risk for withdrawal symptoms in the baby that would need escalation of support, admission to the NICU, reviewing of if breastfeeding is a good option or not. We can do different types of care with medication assisted treatment versus non-pharmacological care. We always want to see if we can reduce the opioid exposure to this developing brain. And then also looking at a safe discharge process where social work and potentially CPS is involved.
And I just have one more thing to add that I think is really important to mention, and not to be negative or anything, but I know what we've seen with our program, and Dr. Nagar or Dr. Kamyar, you might have more of the statistics, but I know we see that individuals or women in that postpartum period have a higher chance of relapse. And so I think it's another great opportunity to provide them with resources or support for them to engage in prior to that time happening. And then that's if it happens. Of course, it's amazing that she's at 14 months and doing well in recovery. But we do know research supports, and what we've seen with our program, that there is a very high risk of relapse in that postpartum period.
Yeah, and along those lines, like Rachel had mentioned, actually, we find that it's possible that during pregnancy, it can be a little protective in risks of morbidity and mortality, aka overdose or return to substance use. But definitely in that postpartum period, particularly that first year, is the highest risk of overdose, maternal death.
Important considerations. And Sharon, would you add anything from a child welfare perspective about this case scenario?
I think it's important to acknowledge, like Rachel indicated, the mom is doing great, positive things that we should acknowledge those things. We want to take into consideration in this scenario that there are two different jurisdictions. And so we're looking at the rural area as well as Clark County. And so there might be information that we need to collect from the intake level as it relates to any previous history or involvement with the 12 welfare system in the rural county, and making sure that we factor that information into our decision making. If we are looking to support this family, what family supports, what natural supports do they already have? Not all reports are going to rise to the level where the Department of Family Services or another jurisdiction is going to be involved from that 12 welfare system. But we have those preventative, and people don't realize sometimes that we do offer preventative services. They hear specific things sensationalized about child welfare and things of that nature, and their immediate thought is that I'm going to be in trouble or they're going to take my child. We have processes in place, we have policies and procedures where we are required to have conversations, gather as much information as we possibly can so that we are not traumatizing children or families, but offering to be of assistance and support when it's needed. And that support doesn't have to directly come from the child welfare agency. We could be that in-between layer that connects to other resources within the community. And so when you are in a situation and you have information and you're looking at the positives and you want to look at a family in totality, not on their worst day, but how does this family function on an ongoing, regular basis? And who is there to support them in that effort? We have a very transient population in Las Vegas, but that doesn't mean that people haven't made connections since they've been here and can reach out to those supports. And if you can work with a family, then we want to be able to work with them. But if we don't need to be involved and the community can come together, their community, people that they identify with can be there, can be a support, willing and able to be able to assist them, then it's not necessary that the child welfare agency has to remain involved or initially become involved. It's on a case-by-case basis for each individual family. And we want to make sure that they understand that there are services, they can continue on the direction that they're headed with the recovery, and that they have that support, and making sure that we treat people like we would want to be treated. And so when you treat people that way, and you're working with them and you're involved with them, and you can have those conversations and have really that opportunity to engage and to learn more, collect the most information that you possibly can, then we're in a position to be able to assist families. And those that don't need our assistance, then we are not there for those families. But those that are most in need and really need us to be involved to help with them, then that's what we're here for.
Thank you. And Rachel, you mentioned a couple important points about this case, which is that the family lives elsewhere. They live outside of Clark County. So do you want to talk to us a little bit about what should happen ideally in that scenario?
Yes, definitely. So if a plan of care is initiated prenatally or at another hospital, ideally it would be great for that patient to have that form in hand, to allow for a handoff from one provider to the hospital care team, and to facilitate that communication. And really the point of this is not only for the mother to feel supported, but to also prevent a new screening or assessment process happening. We know for our clients that can be a traumatizing experience or uncomfortable experience to kind of have to go through screening and assessing and resurfacing those details again if it's not necessary. So ideally it'd be great for them to have that form, and again that's the patient or mother and infant, for them to have that physically in hand with them. But I do want to identify, of course, as a social worker, I totally understand that it might be very challenging to locate resources or services in another community in which you don't work in. But I know for me, I would do my best to locate any resources to address immediate needs in Clark County, since that is where she's delivering. So if there's any immediate needs, I'd like to provide that client with those resources, but also locate resources that could be helpful for the client as she's transitioning back to her community. And again, I understand that that's not easy. If you're not working there, we might not know the quality of those services, if if that establishment is still there, all those different questions. But like I said, I would, using the internet and some colleagues, would just do my best to locate those immediate services that could benefit the client in my community, as well as locating some for her when she returns to where she's from.
Thank you. We are going to do another training in this series about how to locate resources in the state. I did want to ask Sharon, do you have any tips for where you might start to connect this family with resources, given that they are residing in a different county?
I think that it's important to reach out to the child welfare agency in that county. Would be that initial first step to have those conversations about what resources and supports and things of that nature that they have available in their rural county. And then also making sure to have conversation with the mother or any family member or any person that's there to support her during this process. It's important to have conversations and talk to people. You have to be able to talk to people and relate to them. I know that this is an overwhelming situation to have, different people involved and to have the potential of the child welfare agency involved, but really relating to people on a level where they are, meeting them where they are, and making sure that those services that they may need, that they're accessible, that they're relevant. Also looking at if they have Medicaid, contacting the managed care organization. They're able to provide those supportive services and offer resources and things of that nature. Looking at having them connect with a case manager or a peer so that they're able to assist with any of the needs that they might have. We have a variety of different resources in the community. You can utilize 211. There's the Sober Moms Healthy Babies program, the medical home portal, and speaking with people directly that are in that community and finding out what are those resources that they have as their go-to. Because as we know, some resources are better than others. And so we want to make sure that we're making those appropriate referrals that are going to be the best for this particular family. And if that one doesn't work, having options. Because you may have a bad experience or may have worked with an agency before, you don't want to go there again. So being able to have a variety of different options available and making sure that whenever possible, that they are looking at having conversations too. We know ideally it would be nice to be able to have meetings and conversations and be upfront and in person with different agencies and people. But if that isn't available, still making sure that you've connected with the resources, the names, the telephone numbers, how do they reach out to them, what the process is like, if you know that information, what can they expect, and making sure that the mom knows that she's supported and whatever resources that she might to continue on with that great work that she's doing in recovery. You don't want there to be a lapse in any type of service or anything that's going to be beneficial. And seeing if there is some type of volunteer or some type of advocate or whatever the situation may be for that particular person, but making sure that they have a number to reach back out to you, the person that is assisting them, in the event that they call the number and it's not in service anymore, or that resource is not there. But making sure that you provide as much information and let them know that you're there to assist and to help, and that they are not alone in this, and that they don't have to be afraid to receive services, and that we're here to assist and to help them.
Thank you. So before we move on to our next case scenario, I did want to ask, as a provider supporting the care and treatment of mothers in similar situations, what outcomes would you expect related to medication-assisted treatment? What success have you experienced? What issues might impact a healthy outcome for the mother and the infant? And any services you think would be important to include?
So, as a clinician that prescribes these medications, and when we talk about medication-assisted treatment, also known as medication for opioid use disorder or MOUD, I want to just sort of stress that these medications are the gold standard when it comes to addiction treatment or substance use disorder treatment. What I'm talking about is buprenorphine, methadone, and naltrexone specifically, so much so that these medications should be offered to every single person with an opioid use disorder. And how successful are they? I mean, I sort of call them a miracle of modern medicine, because we're talking completely transformative, 180 degrees. People go from the lowest lows to being able to live the life that they want to live. One of the criteria for substance use disorder is that it impacts a whole bunch of different things in people's capabilities and ability to function. And these medications completely turn things around to the point where folks are taking them like they would medication for any other chronic issue, let's say diabetes or hypertensive medications, and they get to go about their day and do whatever it is that they want to do. Rachel can definitely speak more to these life-altering turnarounds, but we're talking being able to reach and achieve educational goals that they've had, occupational goals, engaging with family, social relationships, whatever it may be that you think might be something that can be impacted is.
Right. Yeah. Just to piggyback that, I would say clients are really given the opportunity to really reach stability and have a chance at resiliency. So like Dr. Kamyar mentioned, if they have the goal to enroll in school or complete their GED or start employment, with being sober and being in treatment and working on their recovery, they have the opportunity to do that in a healthy way, to actually make healthy choices, engage in the supportive services, and stay compliant in those services to really help them reach their goals. We see it all the time in empowered clients that once they're more stable in treatment and able to make those healthy decisions, they're then able to clearly identify, what do I want for myself? What are my goals? What do I want for my family? And like Dr. Kamyar mentioned, that could be reunifying with other children. The list goes on for what we've seen. Clients that can then have an opportunity to maintain stable housing, that could be gaining income, getting their children enrolled in daycare, all the documents and things that requires, right, to be stable and work towards that level of resilience, whatever that is for them. They actually have a clear, realistic opportunity to actually start addressing their goals. And that's what's beautiful about clients being in treatment. And also, like Dr. Kamyar mentioned, the criteria for substance use disorder, there's a lot of things for them to meet full criteria. There's a lot of things that really are not going well in their life. So they have a chance to really start changing everything around completely. And that's a beautiful thing to watch, whether they have untreated medical concerns or mental health conditions that they haven't been addressing. They can now start addressing those, and it feels better to be healthier and working on yourself physically and mentally, and of course all those other areas that start to fall into place. It's amazing to watch clients gain stability and work towards resilience, and being in treatment gives them that opportunity.
And I can't reiterate enough what both Rachel and Dr. Kamyar just said. It is absolutely amazing to see the changes that these women are making. They're seeing and envisioning a better life for themselves because of their baby. They're thinking about their needs of their baby and their families. And because of that, the commitment level is just by far higher than I have seen in a lot of other medical issues. I'm so impressed with the amount of work that they're doing before delivery, after delivery, and being there for their baby. During the whole hospital stay, we have seen a huge change in the hospital course for the baby and even the withdrawal symptoms. In the past, there were babies who were in the hospital 3 months, 6 months because of withdrawal or going home on medications because of some of the substances they were exposed to. But as we work through different processes, empowered, getting the mom the care that she needs, putting her on buprenorphine, we actually have babies whose moms are on buprenorphine who are not withdrawing at all and going home. So we're seeing a huge improvement in the exposure to opioids, but the emphasis really needs to be on how impressive the work of the mom and the family is to try to do a better process and have a better life for herself and her baby.
Thank you all. So we're going to move to case scenario number 3 now. In this case scenario, a 40-year-old patient with 2 other children presents at the hospital at 38 weeks in labor. She has a history of chronic pain and has been taking hydrocodone for 2 years. The care team is concerned about the risks associated with use during pregnancy and the degree to which the patient is able to function and meet major responsibilities like caring for children. When offering a plan of care, the patient initially declines to participate. So in this scenario, how would you approach determining if this patient meets the criteria for a plan of care? And how would you work with the patient and family to develop a plan of care?
Thank you, Crystal. So first of all, the definition of an infant affected by substance use in Nevada has to be defined. This definition includes an infant defined as a child less than 1 year of age has been determined to be affected by a legal or illegal substance and or whose mom or mother has a substance use disorder. According to Substance Abuse and Mental Health Services Administration, SAMHSA for short, substance use disorder occurs when recurrent use of alcohol and or drugs causes clinically and functionally significant impairments such as health problems, disabilities, and failure to meet major responsibilities at work, school, or home. So there was extensive discussion about this with Nevada Perinatal Health Initiative core team, and that is why it was important to include the and meets criteria for a substance use disorder in the definition. Use during pregnancy may have impacted the baby in multitude of ways. In utero, meaning while the baby is still inside mom, baby could be affected by any of these substances and have issues of poor growth, may be born early, may have seizures, may have birth defects, and several other issues that just too short of a meeting to be able to go into. However, after the baby is born, babies can start having symptoms of withdrawal within 24 hours, up to 2 weeks, and sometimes even longer, depending on the substances they've been exposed to. Some of those symptoms can be trembling, high-pitched cry, sleep disturbances, high tone, but they can also include symptoms like having difficulty with feeding, vomiting, diarrhea, sweating, temperature instability. They can have seizures, They can have a prolonged hospital stay because of some of these symptoms and need additional opioids to help them treat these withdrawal symptoms that slowly have to be brought down or weaned off before they can go home safely. That can be a very challenging process. We also obviously always want to have parent involvement in this, because holding the baby, soothing the baby, taking care of the baby in other ways that are not associated with medications actually are very key to both the health of the baby, but also the bonding with the mom. And it can be really challenging when a baby is crying and shivering and having a lot of difficulties. So it would be really important for members of the care team to engage with the family to understand if and how the substance use is affecting their daily lives, and how we can help the baby go home to a safe environment. In this case, a plan of care would be absolutely appropriate.
And I just wanted to kind of piggyback on that. The case scenario mentions that the care team is concerned about this client, about her use during pregnancy, and how it might be impacting her ability to function, as well as take care of her current children. So I'd just like to add that I think it's important for the care team, when discussing observations with each other, to be clear on what are they seeing, what does that look like, what does that level of her being impaired or her lack of ability to function, what does that really look like, and who's making those observations. And I think that'll help not only the care team feel supported, but just having that necessary supporting details when completing the CARA Plan of Care, as well as notifying Child Protective Services. The case scenario is kind of vague, but I think it's important for, again, the care team to really take into consideration what are those specific observations that they're seeing, whether or not the patient is managing their pain with help, or if there's additional concerns to highlight.
Go ahead, Sharon.
It's important when we're working with families to acknowledge that this is a voluntary process. And so making sure that they understand the intent and the purpose of what the plan of care is and what it's not. A lot of times people may not have that understanding. And so it's really important to share that information with them. What information would you want to know if you were in their situation? So putting yourself in their shoes and making sure that you explain to them at a level that they're able to understand that it's voluntary, because we don't want to infringe upon people's rights. And so we don't want to force them into something that they're not interested in participating, but how it could be beneficial. Talk about the benefits to it, and that they are a part of this. This isn't something that we're doing to them. It's something that we're doing with them to assist them with areas where they've identified that there's a need for additional supports. And so when we provide that information and making sure that when that report is made to the Child Welfare Agency, if they've refused to participate, then it should be noted on the form that goes to the Department of Public and Behavioral Health. But also when we have that conversation with the Child Welfare Agency, it's important to be as specific and detailed as possible with as much information as you have currently available to you, so that we can make an informed decision and conduct our assessments and determine what's the best approach to this working with the family. So once again, intake would be that initial assessment and having those conversations about what it is that we have, what the concerns are, how it's impacting the child. There are other children. And so Child Protective Services, we are here to ensure the safety of children. It was indicated in the scenario that there were other children in the household, but we don't know that household dynamics. What makes up that household? Who lives in the home and who has caregiving responsibilities? Because it comes to our attention, doesn't mean that we will be the people who respond necessarily. It depends on what resources, what supports are there, who's in the household, if they're going to care for the child or not for the child. Sometimes people have people who move in with them, family members, or people who are fictive kin, not necessarily blood relation, but have a relationship with the family. They move into the home to assist with families and things of that nature. So we need to understand the dynamics and the family functioning and who's going to have the responsibility and what those responsibilities are. We want to make sure that children are safe. If you can do that on your own without the involvement of the department, then by all means, we want families to be able to be empowered to do that. We want to be involved with the families that need us to be involved with them to assist. They don't have those resources, they don't have those supports, or they haven't made those connections, and we need to be a part of that process. But ultimately, we have to do an overall assessment of the family. It goes from intake and then potentially to our next layer that does their ongoing assessment to provide for the care of the family. And we also have that middle layer where we have someone to go out into the home to assess for that family and make a determination. Child welfare cannot do this without the community. The community is a vital, important part of this process, from providing the information initially, from being involved with us in partnership to work with families, to provide the support that they need, the services that they need, and to ultimately ensure that children are safe and that families are thriving.
Thank you, Sharon. That concludes our discussion. I want to thank our discussion panelists and encourage those watching this training to visit DPBH's website for additional resources. Thank you all so much.